You know, single payer system, I think the real problem with single payer in this country is probably the political feasibility. And the only way that it flies is if you start talking about it in the context of, say, Medicare for all. I think single payer there'll be some new organization. People already in this country don't trust their government enough with the organizations it has already. And so it would have to be built on something that exists already. I think realistically what is going to happen is probably a long, painful process where we begin with some kind of an employer mandate system, you know, something akin to Massachusetts or the original Clinton plan. We go through that. It fails miserably. Healthcare costs continue to rise. Maybe uninsurance is mostly eliminated, but there still remain cost and quality problems. And then employers get more and more cranky about being on the hook for this. It's a global competitiveness issue for employers. I know a lot of people who are in head positions in companies who would love to get out of the insurance game, who would be thrilled to not have to do that anymore. And at some point, then I think you end up having a realistic discussion. I mean, at this point, I don't think the political landscape is viable for single payer, and that's very pessimistic, but I think it's the truth. At this point, the two proposals on the table are Senator Obama's, which as far as I can tell looks roughly like Massachusetts is. It's kind of the cousin of Massachusetts, starting with insuring children, which is very easy to buy into socially. And McCain's proposal, as far as I read it, is dismantle the entire employer-based health insurance and give everybody a tax break that would amount to $5,000 for a family to buy health insurance. Last I heard, health insurance costs, yeah, I know. How much does your health plan cost when even if you're buying it through your group, through your employer?
Well, my family is $1,000 a month.
Right, $12,000 a year is about the average. So I mean, you know, you've got these two proposals, one of which is very, you know, actually has some of the components that would easily build into either eventually this evolves into Hal's plan, or eventually it fails miserably, and then finally people decide they're going to get around to doing single payer. And I think that's the political reality. You know, and maybe McCain's proposal would result in single payer more quickly, because as soon as you dismantled the employer-based healthcare system, I'm serious, if you really want to be pessimistic here, or opportunistic, as soon as you dismantle the employer-based healthcare system, the share of people uninsured almost certainly will go up even more. It'll become even more of a middle-class problem and not just a problem of the work, you know, of kind of the mid to low working poor. And then maybe we get single payer, and that's really depressing.
Okay, we'd like to open up to the floor. I know you're all anxious to talk, so yes, sir.
I have two questions. The first one you touch on occasionally, and that is, I read in the New York Times recently that the Massachusetts plan, much to a lot of people's surprise, seems to be improving from what people said about it before. And I'd like to know whether there's any future in that. The second question has to do with the cost of medical care today that really puzzles me. We're covered on a plan. I just had an MRI. The cost of the MRI was $4,000. My insurance company paid $500. It doesn't make sense to me that an uninsured person who's poor and hasn't got a penny to his name is going to be saddled with $5,000 charge that I could afford, but he can't. Why don't they just lower the prices? The $12,000 a year that she's paying will come down to maybe $6,000. Everybody will get about the same amount of money that they're getting now, and it'll be cheaper for everybody. Now, I'm not pushing McCain or Obama. I don't know what the solution is. I'm just asking questions.
Well,
Can you repeat the question?
Okay, so there were two questions. Have you followed Massachusetts that closely? Okay, neither of us has followed Massachusetts that closely. What I have read is that there have been hitches, which everybody expected, and that I think they've adjusted some of the payment levels and so on, but at this point they're feeling like it's working better than they expected. Yep, and you know, it's worth keeping in mind that the state of Hawaii has had an employer mandate for, I don't know, 20 years at least?
Back to 73.
73, yeah, because I had a classmate in grad school who did a dissertation on the Hawaii plan, and that was a while ago. I mean, so Hawaii has had an employer mandate, and their uninsured rate is like 3-4%. It's very low. It's come up a little bit. As far as the payment and the billing thing, the current payment and reimbursement systems to providers, to hospitals and doctors, is a little bit crazy. And I mostly know what the hospital numbers play out like. So hospitals have this mystery thing that's called kind of the charge master, Right. So they have a list of here's everything that we do and the charges for it. Now, these charges are not quite pulled out of a hat, but they're based on some kind of historical how much it really cost back when they really got paid what they billed. And they have just escalated them up. But there's some amount of nobody actually pays that. So they have this charge master, and then they go to different insurance companies who then all negotiate discounts off the charge master. Sometimes it's a flat 20% discount. Sometimes it's we will pay you this amount of money per day that a patient's in your hospital. Sometimes it's more like what Medicare does, where it's a payment per diagnosis in the hospital. But nobody is really paying that except for the self-pay, the so-called self-pay. Who's that? The occasional very wealthy person. I mean, you know, there are the executives who come in from Japan and go to Stanford and get everything done and pay cash or whatever that story is. And then there's the poor. And it is completely ironic and I think morally ridiculous that a person who's uninsured is going to get sent the bill for $4,000 when nobody who's privately insured would ever get that bill themselves. Now, there are a few hospital companies that have been taken to task over this and have been saying that they are now going to charge the uninsured the lowest amount that any of their privately insured patients would pay. And this has usually come from, like the first case of it was Tenet, which basically is trying to recover its image after being busted for Medicare fraud. So, you know, there have been efforts to try to push legislation in this direction. As far as I know, that hasn't gone anywhere in any state. But it's a real problem, and that's one of the arguments for having some kind of a rationalization of the healthcare system to address these charges. Why should somebody who's poor be getting a bill for more? And then the sick and twisted thing is that a not-for-profit hospital gets to claim that high, when they don't pay it, which they won't, they get to claim that $4,000 as their charitable contribution. Right. So they're inflating their charity care. So then the not-for-profits, when they state how much charity they provide, it's completely through the roof. It's more than anybody else would have paid. It's totally wrong. I mean, you know, and that's where I don't know that single payer in the end would really be the politically tenable solution, but there are so many things wrong with our healthcare system that all of these incremental improvements, I am so pessimistic that any of them can work, because every incremental improvement I've seen since I've been studying the healthcare system has not seemed to solve any of the core problems of this country. That was a long rant.
How would you like to respond to the question?
I think the short answer, or shorter answer, is to restructure the system so that when hospitals compete, they have to compete on something meaningful, particularly a bundled price. And where I would be starting is I'd let the Universal Coverage Pool, which would be a semi-public agency, set that price based upon the national average of the high-quality places, and then say, you can charge whatever you want beyond that. And it then just flows back down to those people who want to buy reinsurance, in essence, to cover that differential. And they'll be pushed back very quickly and markedly reduce the amount of people in the billing office, in all that negotiating and all the contracting. From my perspective, that's dead weight loss.
I want to just respond from the perspective of a physician in private practice. My Medicare contract says that they will pay me either a percentage of what they call usual, customary, and reasonable, which we might call the Medicare price, or they'll pay me a percent, I think it's 60% of my lowest price. So if I want to do a physical exam on people and I want to give a discount to people with blue hair and I want to charge them only $10, that's my lowest price. All my Medicare patients are entitled to pay 60% of $10 all of a sudden. This prevents me from charging a discount for cash pay patients. I will essentially get bamboozled out of my, which is already a very tiny amount, my Medicare money. Medicare does not pay the private physician well, as was alluded to, you know, Marin County. We're in Santa Cruz County. We have the same problem. Primary care physicians are dropping Medicare like, you know, it's going out of style. So the only solution I have, because I have a lot of cash pay patients who are not insured, is to offer them a prompt pay discount. If they pay me at the time of the service, I can give them a discount. whatever I want. You know, I'm currently giving a 30% discount. I can also give an individual hardship discount if I want, but then I have to like document in the chart that. But they have to pay at the time of. I can't do a payment plan. And that's because of the Medicare contract. Now, if the Medicare would change that and they would just say, this is our price. If you want to be a provider, we will pay you this price. They could get rid of that, and I wouldn't have to charge double what I think I should get in order to make sure that I get what I think I should get. It would be a simple reform.
Thank you. Thank you, Alexandra. Okay, there was another question back here. I think I might just move this mic back and forth. Okay. Oh, actually, he had first. Paul was first.
One of the things that seems to be a basic assumption here is this tremendous value put on choice. And I guess I'd like to throw that open a bit to some discussion. Yeah, we like to choose our primary care physicians because to a great extent it's not so much about their supposed technical competence, but about how we can relate to them and what they are as people and how we do they listen, et cetera, et cetera. And yeah, beyond that, when it comes time, like you know, to get something serious done, you know, you get referred to a doctor, a specialist, and you don't really develop a bunch of a personal relationship with that person. You maybe do a little research to see if you know, any statistics on their you know, how many of whatever it is they do and so on. But you kind of go with it, and you know, you don't shop around very much. And yes, I'm wondering, you know, where we whether we're kind of overblowing that as a resistance issue to change. So I appreciate any comments on that.
Well, I think there are two aspects of the question of choice. Americans just like having choice. They like going to restaurants with a lot of items on the menu, even though they choose the same thing every time. That's okay. I think the issue that really plays out is if you're going to externally restrict choice in one way or another, then what are the criteria that you use? You say, well, we really only need one orthopedist in Santa Cruz because we're not that busy. Okay. Do you get the one who does hips, knees, or ankles? Because they really specialize in different areas. So for somebody, sometimes you do need that specialist. You do need to be able to send that patient to San Francisco or Stanford or somewhere else. So sometimes the choice matters. Maybe not very often. But you can be sure that when it comes to the political debate, they will cart in the patient who got the bad surgery because he or she, quote, didn't have the choice. And so, again, this is the political issue rather than a real, you know, how important is it? It's certainly important to that one patient, and it'll be very important to that specialty society to make sure that there's as much choice as possible.
I think there was a subtext to your question and your answer, though, that I want to make explicit. That that the U.S. is overloaded on specialists, on specialty physicians. If you wanted to design a rational system from scratch, the fairy godmother came in with her wand, what would you probably do? You'd probably have a lot of primary care doctors, internal medicine, pediatrics, family practice. Your first point of contact would always be that person. You need to see a specialist, that person would recommend a specialist. They'd recommend the right specialist, the knee surgeon or the shoulder specialist or whatever you needed. Or, you know, maybe they'd start at one level and then you'd get referred up the levels. Your population of doctors would end up being a lot of primary care and then a pyramid where the super subspecialties would be very, very few. Our system is basically the inverse of that. We have a ton more specialists than we do primary care doctors. So when people talk about their choice of doctors, I think many people are thinking about who their primary care doctor is. And at this point, because there are so few of them, I'm not sure how much choice people really feel like they have. You know, and even on the specialist line, I was talking, I'm in specialist land right now with my daughter. And, well, gee, the Stanford group that's got this specialty has a 6-month wait. You know, whereas Kaiser's a 1 week wait to get in. You know, so how much choice, do I care about the choice when I got to go in a week instead of wait 6 months for what may or may not be a relatively routine thing when all is said and done. So there are points at which that choice really, really matters, and at points where really what you care about is competence. And that's a discussion that I think gets very confounded. And of course the specialist lobbying organizations are going to play it one way, but for patients it really does come down to, I went to a provider who understood my grandfather's cultural issues and could help him navigate the healthcare system. Or I just really liked this nurse practitioner who took care of my kids because she was spunky and my kids had a good role model. I mean, whatever it is that you like, that's fine. But right now the whole deployment of physicians doesn't really play well to those choice opportunities. And a socialized system still can provide choice. My understanding is in Canada, at least at primary care level, you do get a choice. And for specialists, you probably want the best person no matter if they're a jerk.
Can I make a comment on that issue?
Yeah, as a physician, I'll have two brief comments. One is, as Dr. Spetzel mentioned at the end, that system that was described already exists, and that is Kaiser. Kaiser has that system, and if you want that system, you can go to Kaiser, and that's readily available right now. Second comment is that some people like choice because they do want to have a different kind of relationship with the physician. I mean, the one thing about having different kinds of choice preferences in this country is that if you want to pick a specialist, you want to be able to go. You don't want to be. Let's see how I can say this. You want to be able to have a person that you are comfortable with. Some people like a touchy-feely relationship. Some people, a lot of engineers in the room probably, just are very functional. They say, you know what, I don't care if the guy is a prick or not. He's going to do the best job on my valve replacement, and that's all I care about. Some people are very uncomfortable going in to see somebody that, that they just think is a machine, and they have no sense of, no values.
I'm not from MIT, but thank you. My specialty is OBGYN, and in OBGYN we have the issue as a primary care physician and also as a specialist. So I see this perspective of choice slightly differently. Patients will come in and they will have a certain problem. If you go to one doctor, you'll get a surgical solution. If you go to another doctor, you'll get a medical or hormonal solution. And so that kind of information does percolate around a smaller community. I also work in Santa Cruz. And so patients want choice because they're different practice styles. One office, you'll be booked for surgery within 15 minutes. The other office, the physician will work with you for several months and try medication, minor surgical procedures, and then do the ultimate if that's required as the last resort. So choice in that aspect is sometimes based on word of mouth in the community and also practice styles. And a lot of attention should be given to how do we really manage patients optimally, the clinical evidence-based medicine, so that you don't walk in the door with pelvic pain and get scheduled for a laparoscopy when actually what you really have is chronic depression and an abusive spouse. And that's where choice does make a difference. And it makes a huge difference in the cost to the system.
Thanks. Okay, was there any other questions? You had a question, and then, yeah. Is this about this topic, or is it a new question?
I had a couple of points, and then I do have a new question.
I've got Ruth. She was keen to ask a question, and save your points. We're not going to lose them because I think they'll be good. So hang on, and we'll be right back to you. Here you go, Ruth.
Okay, I have two questions of fact, and because Dr. Luft is a medical economist, perhaps he will answer them. We both are. Oh, you both are. Oh, okay. Well,
I went to Stanford, which is better than where.
okay.
That's the Stanford answer.
Okay. The first question has two parts. One has to do with Medicare, and what is the percentage, dollar-wise, estimated of fraud in the Medicare budget? The second question has to do with, again, it's a percentage. What is the percentage of total costs of healthcare delivery in this country for end-of-life issues? Let's say the care during the last year of life. And I'd like the answers to this so that as we think about this problem, we'll have an idea of where the resources are now going. I have one more later to think about. To Dr. Luft, in your overview of the supply of pharmaceuticals and other things, is there any room for what are now called orphan drugs?
Thank you, Ruth. 2 questions.
I could swear one of these things I printed out has a comment on fraud, so I'm going to look out for it while he answers the others.
I don't know the percent of fraud. It partly depends on who you talk to. The federal government right now is trying to label a lot of things as fraud. There are recent reports on hundreds of millions of dollars in durable medical equipment with prescriptions being written by physicians who are dead. That could truly be fraud. It could also be, I mean, a lot of this DME is like oxygen. That's getting renewed every month. The patient's still alive. The supplier may not be going back to find out, and ask for a refill. There's a lot more stuff that gets listed as fraud, which is really inadequate documentation. The procedure was done in the hospital, particularly a teaching hospital, by a resident. The attending was around but didn't sign. That's fraud. Not from the patient's perspective. The patient knew that the resident was going to do it, but it's listed as fraud. There's probably a lot more fraud of things that are being done that probably don't need to be done, but it's not fraudulent, okay? Because it was coded appropriately, with the right diagnosis, the right procedure code, billed appropriately, and that's not listed as fraud. But it was being done to somebody with maybe the hope that it'll work. So I don't know the answers on that. In terms of cost of the end of life, there's a number that, do you have it?
3% among all health insurance, including Medicare, is the best estimate.
Okay.
There you go.
In the last year of life?
Oh,
No,
total.
fraud. Okay.
That's fraud.
Okay, that's fraud. Okay.
Yeah, got that number. That's kind of, I mean, but that includes private insurance. One of the things that this article is pointing out that I brought with me was that fraud is a private insurance problem, not just a government problem. But when people talk about Medicare, they always say Medicare fraud, and it's going on in the private sector.
Yeah.
You need the mic when you do that.
In terms of end of life care, the number that I think is in my head for Medicare is about 15%. The problem is that very few people know when they're entering their last year of life. And often, and actually a colleague of mine did a very detailed study of this and looked at expenditures. What happened to people in their last year of life? And most of the expenditures were not what we think of as terminal care. The patient is, about to expire and they start doing surgery and do this. No, it's they've got congestive heart failure and they go into the hospital 4 times during the year, and the first 3 times they survive. You don't know when the last time is going to be. So what actually some people are beginning to think about is providing opportunities for patients not to choose hospice care, which is designed to be the last 6 months, but sort of late life care in a sense. When you think it's the last 2 years, when you have something like congestive heart failure or congestive obstructive pulmonary disease, you know that you're not going to get really better. You'll have acute exacerbations. And what you want are clinicians who will treat what can be treated, who won't treat what's not going to really be helpful, who will work with you and the family and everything else, and that may actually lead to some real savings. That's very different. That's not pulling the plug. That's saying, let's think about where you want to be going.
Yeah, I don't know off the top of my head the cost of the end-of-life care, but Hal landed on exactly the issue. If you don't know when that's going to be, it would be great to see a system that was more supportive, though, of the kinds of alternative care that people might want as they reach certain ages, and also just some basic educational things. I remember when my grandmother hit 80, she said to her doctor, I don't really want mammograms and pap smears anymore. And her doctor said, well, now some doctors might have pushed her on that. Maybe they were in a managed care organization where they get scored by what % of their patients get their mammos, even if they're 85 or something. Whereas, my grandmother said, yeah, so you find breast cancer. What are you going to do? I'm 80. Right. Well, of course, but she felt like she didn't want it to be. And that's a very personal choice. And so for some people, they may have a life expectancy of 105 and they should go fight it. My grandmother lived to be 92 and, just gave up on the screenings. And so support in those personal choices, and for the reimbursements and the quality incentives to providers to not thwart those options, I think are key. I think the problem with a lot of the quality metrics now is that they're really a blunt instrument, and they don't always reflect what the patient's desires are.
Okay, thank you. And you had a question and some points.
I've been jotting down some notes here. The first one was we were talking about the costs to the poor relative to those who are insured. And in this country, the last I heard was that half of all bankruptcies are medical related. So not just the hospitals are out the money, but all the creditors of all the mortgage people and everybody pays when that happens. The second note was that on the whole choice thing, choice often means trust. You get buy-in. So when the doctor says, you'll probably get better, if you've chosen him, chances are you'll believe him. And often, that's the right thing. Just tough it out. You'll get better. Take 2 and call me in the morning. Often works really well. The question I had was, as a consumer here in town, when my son sprains his ankle, I have a choice. I can take him to the emergency room, or I can take him to my podiatrist, right? Interestingly enough, my podiatrist saw him in 20 minutes and cost me a quarter of what the emergency room is going to cost me. So when I look at all this, I'm curious how the payer systems can inspire more efficient, reasonable delivery of services to non-critical, yet your son just sprained his ankle. You want to get him seen, but an emergency room is just radical overkill. And we don't have a large number of just walk-in Saturday afternoon after soccer clinics. How can the payer system help us deliver services more cost-effectively?
Thanks. They have a lot of those type of clinics in New Zealand, by the way. Here you go.
But they don't work on Saturdays.
Okay. Yeah. Right. So right. Okay. So the question here is, how can we encourage a more responsive system, particularly for the minor kinds of problems? And there's not a car accident with major trauma. This is a bad ankle. You don't quite know what needs to be done there. So part of what, again, I'm proposing is that would be in that part that's not normally covered. You might buy an insurance plan or not, and the providers could set whatever fees they want. They could say, you want to see me on Sunday? It's an extra 20%. And you'll be happy to do that. If your son really did break his leg and went to the emergency room and got taken in, that would be fully covered. Okay? But on the other hand, if you go to the emergency room for an ankle sprain, that wouldn't be covered. And you don't know, but what would start happening is your podiatrist or some urgent care site in Walmart would say, we'll figure out how to make that quick triage decision. and help you through this. Or you might even find your primary care physician saying, here, can he bear weight on it? What does it look like? I'll have my nurse call you back in an hour and see how he's doing. And that's part of the normal fee, and you get a charge for $25. You might be quite happy with that.
I think the problem, again, with the disjointed healthcare system is that you don't know who to call necessarily. I mean, unless you know your podiatrist really well. Now, I'm enrolled in Kaiser, and so far I've been happy with them. And because they try to rationalize their system and they're so big, they can do things like have those telephone advice nurses. Those advice nurses, they run the show as far as I'm concerned. My daughter fell off the monkey bars. Did she bruise her arm really badly? Did she break her arm? Not deformed. I don't know. I knew I could have taken her to the emergency room and sat there for 4 hours, so I iced it. I called the advice nurse, said, what do you want me to do? She asked me the usual questions, is it blue? Is it numb? Is it, obviously bad? And said, if your daughter's not in too much pain, you can ice it for 48 hours and see how it goes and then give us a call. 48 hours later, I called and said, not good. We went and saw our nurse practitioner who sent us for x-rays. We went back and they were there digitally. We went to the cast room and we were done in an hour and a half. In an emergency room, how long would we have been there? So in any of these kinds of systems, and to some extent the merging of physicians into larger groups has been, I think, difficult for a lot of physicians, but one of the good things is it gives the physicians more resources to think about pooling what kind of urgent care services do we want to provide, what kind of telephone triage can we provide. And there's really no reason that some hospitals can't provide more of this triage opportunity. I know UCSF has been experimenting with it. And you also could have, quite seriously, people will laugh about the doctor clinic at Walmart, but in a lot of respects, those clinics in the drugstores with a nurse practitioner there who knows when to triage and knows when to send a person to the emergency room can be very cost effective and very much meet these kinds of needs. I know that there's a lot of regulatory hype right now about we need to regulate these, walk-in clinics at Walgreens, but as long as they're providing decent quality care and they send people out for more advanced care when they need to, it sounds like it's got a lot of possibility.
One add-on, people have often talked about Kaiser, the large multi-specialty group practices that can afford the infrastructure, that have the advice, nurses, etc. They don't have to all be in the same building. I mean, that's one of the things that electronic health records, you don't need to be in the same place. You can have those advice nurses in Denver or Bangalore. The x-rays are probably being read there. And so there are lots of opportunities now where you can actually get clinicians together in virtual networks and virtual organizations.